All right, well, welcome to the closing panel. And this is a panel discussion focusing on envisioning the future of digital health equity. So I'll quickly introduce the members of the panel. Welcome back, Dr. Craig, who's an epidemiologist and global health and health systems researcher at UNSW Sydney. Professor Ray Mahoney, a descendant of the Bidjara people of Central West Queensland and professor of Aboriginal and Torres Strait Health at Flinders University. Welcome back, Dr. Roos Pot-Kolder, who's a postdoctoral fellow at the University of Melbourne and Orygen in virtual reality for youth mental health. And joining us for the first time today and fostering an industry perspective is Miss Yupin Robson. She's the co-founder and CEO of Edify Medical. Edify Medical is an Australian health tech company breaking down barriers to the access of medical education through a scalable communication and training platform that can accommodate different learning styles, languages, and functionality. So welcome, everybody. All right, I have been taking notes throughout, and so I'm pulling up my notes about the questions, and I'm thinking about where to start. And first I want to kind of summarize what I think are two different types of digital health equity that have been addressed. And one is that when we develop digitally enabled interventions, how do we consider equity in the design and implementation of them? But the second is, how do we use digital interventions to address inequity? And I think they're different. Maybe they're two sides of the one coin. I'm not sure, but a theme that we've heard from everybody is this idea of true partnership and respect. And I'd like to start with a question about the attitudes that we as researchers or healthcare workers have towards those that are not researchers or healthcare workers. So whether they're patients or citizens, and I think often the lack of respect that we have for them and for their lived experience and for their expertise, and that we don't call it expertise, we call it experience. And just wondering, do you think this view is shifting? How far do we have to go before we really see, true partnership in this, and what do we need to get there? So I don't know who wants to start with that.
I'll give it a go.
Okay.
Thanks, Betty. Yeah, to your first point, I think global health sort of by default, by definition, is concerned with inequity. I mean, at a global level, at a macro level. So, working global health, working all the WHO agents, all the international development agencies are all really there around looking at global inequity. Whether they call it that or not, I don't know. Getting down to the nitty-gritty into the sort of dissecting a population and looking at subgroups within that population, I don't think they do a great job. And maybe that's just by default of the model, the sort of consultant-driven development model that we seem to have adopted in the world, and particularly in the Pacific, where it's difficult and expensive. There hasn't seemed to be time to get down to that co-design and to be concerned with the differences and inequities within society per se, or at least within the digital health space. Is that changing? I don't know. I don't think so. Not in my experience. I think we're still locked into this, chasing the rabbit down the hole approach to development, and that means that everyone's a bit frantic and still repeating old mistakes, and not knowing how to engage with the societies and the end users in a meaningful way. And mistakes happen as a result. And in the Pacific, I can tell you there's 101 examples of digital initiatives which have got up and been the bee's knees and talked about at conferences, which have crumbled as a result after within years of the project ending because of poor design.
Yeah, thanks, Adam.
I have seen a shift, I think, in the last 10 years within the virtual reality space, at least at the start of it. I think there's been a lot of awareness that we want to do co-design and we need to do co-design to have real solutions. But it was, and often has been, one of the first things to get escaped out of the budget. And more recently, we've been doing grant applications as well. And it's actually been one of the requirements of the grants, and making a big part of the request of the grant, about 20%, that there is active co-design, active lived experience, and expertise involvement.
If I may bring to the table discussion of the co-design, I've sat in all day today, and it's been really wonderful to actually, participate as an observer of the training. Just from a very simple point of view, I guess the thing that I bring to the table for discussion is actually language. And there was a lecture earlier on today, and we assume that when we are all of the research and the communication, we often put that out in English. So if you actually even come back from the end users, the patients, actually just the clinicians themselves who are actually living the problem, only 5% of the world actually has English as a first language. And so your peers out there that you're actually working with, their first language is something else. And so that's been my experience, is that initial challenge is actually that train the trainer and the loss in translation that already happens at our region. And actually just here within Australia itself, where we have a huge immigrant healthcare workforce that's actually supporting the patient, we already have a loss in translation at the beginning and the front end of our communications and research. So to kind of even pull it back even closer to the start of the gate of research and design, the language is actually a really big one. And, is that something that we're all thinking about when we're actually designing and building systems and research of actually not having things lost in translation at the gate?
Thanks, Yupin.
Thanks. Yeah, I might jump in now. That's an excellent point. I think everyone's made some really important contributions to the question. Look, I mean, I could probably talk about this for a while, but I won't. But first of all, I'm coming from my perspective and my viewpoint as one Aboriginal man with my own lived experience. And I have a small team of Indigenous and non-Indigenous researchers and colleagues here, and we've been privileged to be exposed to a number of different communities across, I guess I'll say Australia now, because Queensland and Northern Territory. So it may not encapsulate, I don't want it to be seen as like the view of all Aboriginal and Torres Strait Islander people, but a couple of things, I guess from a digital point of view, there's been, like, sometimes I've been surprised with the approach and attitude of Aboriginal and Torres Strait Islander people and their willingness to uptake and participate in and use technology. So certainly we need to try and avoid to make assumptions around someone's age or gender or cultural background, because we seem to be seeing and observing and learning is that in many settings, people are being forced onto digital platforms for day-to-day living. So that's a whole other consideration. And I think there's some challenges around making that connection between, the pervasiveness of digital technology across many layers of our society and lifestyle, social media and different things, and as an application for health. So I think there's still, we all know there's still some work to do there. But overarching all that from an Aboriginal Torres Strait Islander perspective, when it comes to research and co-design, we're still dealing with a very present history of colonisation. That, one of the big legacies of that was that most of the research up until recently was all observational. It was about counting how many of us were still alive and how soon we're going to die, sadly. So there's still a real concern and fear of research, because still, unfortunately, and it's less and less happening, that we still have institutions and academics and researchers that are still promoting research for their own academic credit. So the community is mindful and cautious, but then there's another layer of people just being so flat out with their day-to-day jobs and service delivery that research a, you know, still a step away and a challenge. And we get caught up, you know, as researchers and scientists, we get caught up in our language and our terminology, and it can be alienating. And then you add, as you talked about, language being a second, English not being your first language, and that makes it even more complex. So anyway, I'll hand back to Wendy. Thanks.
Yeah, thank you. Thanks for that. Yupin, would you say a bit about Edify Medical so we understand more about what it does, what you're doing?
Oh, thank you. Yeah. So I spent a long time kind of working in Asia Pacific in a train the trainer role. And what I saw was very much a loss in translation, being bilingual Thai immigrant, was that when we would teach everybody in English, because that's what we do, we get up as Australians, we speak really, really fast. So Adam, actually, at your pace then, nobody in Thailand would have understood you, because Australians actually speak really quickly and they can't kind of catch all of our accents and nuances. So I saw firsthand the challenges. So I kind of just stepped away from the industry and thinking there's got to be a better way of doing this, where it's not the definition of insanity of repeating the same mistake over and over again. So really simply just kind of built a learning management platform that had the ability to have the recorded lecture transcribed and translated into all of the languages, that it's just there. So if you actually want to actually read that lecture in Mandarin, you would just put down the Mandarin button and read it in Mandarin or Thai. And so it's once you've actually made that investment in doing that translation work, that information is just there forever, I guess. You're kind of not having to repeat it again. And in the process of trying to solve this equity and equality in actually getting the information without it being on the burden of the learner always, I guess the now that we're kind of in the marketplace, really talking to the application of the tool itself, it's so broad. We're seeing patients, obviously multilingual patient information needed, First Nation patient information needed, Australian healthcare professionals who are not actually English, aged care sector, primary care providers who actually, they have an English proficiency score of only 5 that's required, actually being able to take information in their first language and actually learn things, you know, correctly and properly, and the burden's actually not on them. So that's Edify, really. We've just created a communications tool that's actually thinking about global inclusion and language inclusion and learning style as the #1 priority in its development.
Thanks. And is it manual, human-based translation, automated, or both?
Both, actually. So we're kind of in our part doing research as well. We're collecting the automation data, but we actually have human translation, a very stringent process with the final clinician actually signing off, who is an expert in that area, to ensure that we actually get correct technical information being delivered. We're collecting that information in a way that we will power more AI accuracy. So definitely looking for any experts out there who actually is in the area of language, because I think the medical translation in the future, as we saw with the COVID pandemic, if we can actually get much more real-time, live, accurate medical translation, that will be, you know, an amazing value, I think, out there to the world.
So when I think about empowering patients with data, that's something that we haven't done yet in Australia. We're behind many other places in giving people access to their data and ownership of it. But even when we do get there, which we will, it's still just data. And what we really need is to really help them with the knowledge that's contained in that data. And so translating it into another language is one of the ways to help, you know, make that closer to knowledge. But I wanted each of you to say, from your perspective, what's another way that you could take that healthcare data and make it, you know, turn it into something more akin to knowledge to support a community that you care about? So maybe start with Ray.
Thanks, Wendy. Look, that's a really important question, and we part of our work with the hypertension platform early on, and you know, it's still part of the evolving development of it, is looking at it and going, okay, if we're looking at what is hypertension, it's consecutive readings of, blood pressure at certain levels, right? Cut it simply. But, we assume that everyone acknowledges the numbers, what they mean. So, how else can we present that for patients? What sort of graph, what sort of, terminology, green lights, red light, that question, is something where we're trying to explore through some of the work we're doing. And is it about sort of having like a number of different ways to present that information, that data, those readings that a patient can choose from, So there, from our perspective, that's one real application. But the broader question for Indigenous people is around data sovereignty and data governance, which is, a very important factor of, further digital health development, ensuring and reminding and ensuring that our people, that our information is protected within, existing health data protection. And that, when we talk about interoperability, that we're part of that discussion around the sharing of our data between a community-controlled health centre and a hospital. So there's a lot to play out around data for Indigenous people. But, we're coming from a position of power as well, because our Aboriginal and Torres Strait Islander community-controlled organisations already have a community governance in place to help guide the that next chapter. So thanks.
Yeah, thank you. Roos.
Yeah, it is interesting because I'm from the Netherlands, and we do have patients do already have access to their files. They can just log in, see what I've written up, see any data on their file. And for the last 2 years, I've been working as a digital psychologist still in the Netherlands as well. And how it is solved there is not perfect. There's still a lot of language barriers. But the visualization has been really important, so that people see this green, orange, red, sort of alarm bells if there are suicidal thoughts, or there might be violence within the home. Sort of little alarm bells are there. And it is something that is a process that you do together as well. So we every 8 weeks, we discuss these graphs with the clients as well. So they know they can ask questions on it from us. So that's a really good development. I think it's great. And hopefully soon in Australia as well.
Excellent. Adam, do you have thoughts about this topic?
Good topic. Yeah, I think, I sort of think upstream and downstream, and I guess it's, in my world, it's a bit of the trustworthiness of data, and whether or not the data that is collected in the first place is considered to be an accurate representation of reality, and whether or not decision makers trust their data. And I think that that's one element which maybe is outside of your question, but is important. I share Ray and Roos' comment about data dashboards and interactive ways for decision makers to access and interpret and use data has been, I guess, one of the ways forward, and some of that work's happening. I could just add the preface that in contexts where not everybody has access to the internet and it's slow, sometimes those tools just don't work and aren't really operable. So people will revert back to their stock standard ways of doing things. And I guess that leads me on to my last point, which was around, in many contexts, and I guess I'm thinking about where I work now, we're really asking people to change the way they've always done decision making, to be more evidence-based. And that's often forgotten when we're talking about digital health and health information exchange. We think that everyone is on board with this idea of evidence-based decision making, when really gut feeling, relationships, experience has been the driver and has been the way people make decisions in the past. So that element, I think, is missing and needs to be kind of plugged if we expect to see more robust, as we would say in the research world, decisions being made based on what evidence is available.
Excellent points. Yupin, you're translating into other languages, which is really helpful. Do you have any plans in your company to go beyond that? For instance, there's sub-languages, there's the medical language, and there's words that even though they're in Thai, they may still not really understand what they mean.
So, sorry, as just repeating your question. So some of the English word into Thai, is that what you're?
Well, I'm saying translating into your native language covers some problems, but it doesn't solve the problem that in medicine, there are different, sub-languages that we use and words that are used in healthcare that the general person may not understand. And so are there thoughts about going beyond just the literal translation?
Yeah, actually, it is actually something that we use as part of our translation key, actually, and it's been a learning process for us as well as the clinicians who are actually translating, the bilingual clinicians. The feedback that we've had originally was that we were actually translating everything and written everything in that native language, which actually was harder for them because that's not how they learn the terminology. So people learn terminology in English. And so it's actually easier for them to actually see the word in English. But in our key, what we have is we translate that particular term. So the word diabetes in Thailand is actually Bawaan. It's like sugar disease. So the doctors call it diabetes, but the language that they'll use with their patient is sugar disease. So we actually have keys that are actually used to tag the different levels of what would you use with each other as peers, or how is this actually communicated to the layperson. So we're kind of going through collecting those information with those instructions in mind as the translation is actually happening, to hopefully try to capture as many nuances as we can along the way. And certainly it's been a learning process, for us, but certainly as a benchmarking against the current system that's out there, we're doing pretty good, but it's much more time consuming. But we're hoping the end game will be to actually have machine ultimately help us. So we're doing it purposefully.
Nice. All right, I want to close with one question that I'll go around and have each of you address. And it's really based on kind of two-way learning. So I have a colleague who has been working in Malawi, Africa for 30 years. And it's a very resource constrained environment, similar issues with electricity outages and, not very many healthcare workers. And one of the main things I've learned from him is that we come to a place like that and we try to put on them what we think are the greatest tools, right? And they just don't work in different environments. And we can see that with all of your projects. But often the innovations come because we're resource restrained. So everyone on this panel is resource restrained in their work, and having more resources would be great. But what have you learned or developed or generated because of the constraints that you have, and because of the different cultural environment that you're working in, that you think that the rest of us could be learning from? So rather than it's always, the mainstream saying, here, learn this, what have you brought forward in your environment that we should be learning from? So maybe start with Adam.
More question, huh? Yeah, good question. Thanks for coming to me first. I'll try and speak slowly. Thank you. I think the lesson, anyway, and we'll talk about the solution in a second, but I think the lesson is this idea of demand-driven, as opposed to, and you sort of articulate in your question, as opposed to supply-driven interventions. And that sort of, I guess, feeds back into that the initial discussion around co-design and what that is and how you go about doing it, and whether or not we really do as researchers and as practitioners invest in co-design legitimately. There's a very big difference between co-design and consultation, and I think we use the words a bit interchangeably in our ivory towers. To your question about what one may do to learn better and do it better, I don't actually know. In my world, it's about just setting up fundamental infrastructure that allows the market, if you like, to take hold and allows governments being the market to work out what they want to do. And those building blocks, the enterprise architecture, to use some jargon, but the workforce and the systems and the leadership and the governance and the standards and the protocols and all that gobbledygooky stuff that we talk about as policymakers is missing, and that needs to happen. But it can't happen in a diagrammatic way where that needs to happen before we then start talking about interventions, because we know that people will jump on every opportunity for an intervention. So somehow the two have to happen in unison. In my work, there's some great work being done around health information exchange using open source software and getting, that's liberated local people, local community members to be involved in the development process. So it started up a whole industry around support because it's open source and, it's not proprietary. I think those sort of changes at a structural level will enable better quality development and bottom-up driven approaches that can be sustained.
Oh, thanks. I was hoping you'd bring that up because I loved your slide with the pyramid at the end, where, having that infrastructure. And I think even in, metropolitan areas like Victoria and Melbourne, you'd say that it's a very different approach than in New South Wales and Queensland, where it's kind of let 1,000 flowers bloom. And I'm off that, being an American. But at the same time, you need to have this infrastructure that supports those blooming flowers. And if you think interoperability might be a good example of that. If you just let everyone bloom and there's no way to support interoperability, then it's a mess. But if you had infrastructure that can really support that interoperability, then it is fine for everyone to have different ways to visualize the data and analyze the data and collect the data and so on. So I think that infrastructure is a really important thing that we often forget when we're rushing to the shiny things.
Yeah. I think, yes, we are all resource constrained. But when you compare Australia, where our IT departments maybe have 30 or 40 people working in them in each state, compared to Ronnie's situation, where he's the only person supporting basically 6 countries, equivalent, 6 different locations. I mean, it's chalk and cheese. So I think we need to come in with some reality as well.
Yeah.
Something if I may jump in, I think asking the right groups of individuals for the problem is really important. And what I see is that certainly as we're top scientists or top doctors, they're the ones that actually get a seat at the table, but not actually doing the grind every day and seeing the issues or, interfacing with the problems. And often the representation that comes to the table to co-design or co-develop don't have the real nuances of the issues every day. So again, when I was developing Edify, I was thinking about what does that nurse or that doctor, junior doctor on this ward in Calcutta, what are they thinking? How do they get their information? Because there's probably 50 people above them that filters that down. So again, to your point of what are some of the challenges? I think getting the right information, is that data actually correct? Because that source of that data that's coming has obviously a whole bunch of biases potentially already at it because it's not their lived experience.
Yeah. Rose?
Yeah, I've been thinking, but what do we do when we run out of means, because that happens all the time. I think it does come back to what my colleague mentioned earlier, that is relationships before partnerships. That once we fall back on our network and we ask people for help, and also just in our everyday life, from for example the pictures we needed to make people virtual, which is interesting because I did get a question about after my presentation on crowdsourcing, and that would be ways to make virtuality more available and accessible. And we haven't used that in that way, but thinking about it, I think we did use forms of that. Absolutely. Yeah.
Excellent. So Ray, I think
Thanks.
that your comment of relationships before partnerships should be the motto of the symposium. I'm going to put it on a t-shirt.
Well, look, we've got to be careful because Andrew and I have got, I think we're waiting for the trademark to come in. So commercialize that for you. But yeah, look, this is just hearing from you guys, your responses. It's fantastic to get some really good ideas. And I was reflecting on the idea around how, who are the experts, who do we draw on around, particularly around co-design and developing things. And, in our case, in our sector, in our community, sometimes it's the same people that keep getting drawn on, and they're very busy people. So it is a challenge to, really sort of get in touch with people. But having said that, having Aboriginal and Torres Strait Islander people at the table, most of us can bring, our own unique perspective to those discussions. So it's important that, where we can, we do that. And on the point of not innovation, but, how do you make, what's the solution when you don't have good resources? And the interoperability, I know it comes up all the time, right? And like, we know that the solution, for health systems in Australia to be truly interoperable is a massive, expensive exercise. So like with the platform we've been using, talking to patients or about, okay, so if you're recording your medication on your, on your mobile phone in the platform and some readings, and while the Aboriginal Health Service can see that, when you're at the hospital, you can show them on your phone what you've been recording. So it's not true interoperability of, electronically sending the data, but it's a bit of a solution to going, well, look, this is actually what's been going on, rather than sort of waiting for the doctor to fax, which we still use, fax the information. So there's sort of little things that people, come up with along the way. But just to sort of finish off, I've been lucky to bring my training in public health and my development and experience in research sort of together, and just to sort of touch back on the relationships before partnerships. I mean, we didn't go into doing this work with an idea that we were going to sort of focus that become a focus of Andrew's PhD, right? That's sort of like going in to develop an intervention and conduct a feasibility trial for a ML platform. But along the way, analysing and reviewing and reflecting on and looking at the process we've used and going, well, actually, there's something in here that we can also develop as a translational tool that can support other people to work in our space. So that's one of a number of things where, while we went at it particularly from a scientific and a research point of view, to develop that, to do the work around how to adapt the platform, we've been able to develop and produce additional valuable research.
Yeah, wow, fabulous. Well, thank you so much to all of you who on the panel, and everybody who participated today, everybody who spoke today in this amazing symposium. I want to offer a special thanks to Cara, Mahima, and Simone, who just, set this up for success. It's so organized. I've got my notes with the pictures of the slides, so I know exactly where I am. But not only that, they were the brains behind, the speakers. It's the speakers that made this event really special. And they went out and found all those people so that we could get this diverse representation of ideas and experience in today's symposium. Want to thank the Network for Equity Through Digital Health, or NEED, Monash University, and CADE at the University of Melbourne for co-sponsoring the event. Just a reminder that we are running a competition for the best equity-inspired haiku poem and picture, and winners will receive a prize. And we're keen to get your feedback on the event, so please do fill out the survey that's been put into the chat. And if you'd like to know more about what we're doing at the center, again, feel free to email me, wendy.chapman@unimelb.edu. And this is the second in our series of making digital health real, a practical reality. The first one was on virtual care. This one's on digital health equity. And if you have any thoughts about what the next one should be, we'd love to hear your thoughts about that. We'll have a workshop on Friday where we'll really work through real problems and using different instruments and frameworks to think about equity, digital health equity, and in the digital health solutions that we're developing. So thank you, everybody. Have a wonderful day, and we'll see you next time.
Bye, everyone.
Bye.
Bye.
Thanks, everyone.
Thank you.